Welcome, dear friends, colleagues, to today's webinar, Critical Care Sunday webinars of Young India Intensivist. Today's topic is applied pharmacology of hemostatic agents, all that we use to control bleeding, bleeding being a significant factor and a significant problem in the ICUs. So he'll be discussing the applied clinical pharmacology, telling you about all the drugs and agents that we use. So Dr. Sauvik Maitra, who's additional professor, Department of Anesthesiology, Pain Medicine and Critical Care, AIIMS New Delhi, will be speaking on this. He has a large number of publications, around 150 publications with 5,000 citations. So that's a remarkable piece of work. And I am sure all of you will learn much from this. Any questions we will take in the end. Over to you, Dr. Sauvik.
Thank you, sir. In the next 45 minutes or 1 hour, so I will discuss the clinical pharmacology of the hemostatic agents, the agents and drugs and different agents that are used to control bleeding in intensive care and to some extent in perioperative medicine also. Now, why do you need to learn about hemostatic management and what are the clinical scenario where this hemostatic management is important? There are 5 or 6 specific clinical scenario because of pathophysiological reason, the hemostatic understanding of the hemostatic management is important. Firstly, the patients who are undergoing major surgery, so management of intraoperative and postoperative bleeding. As all of you are aware of the fact that major surgery causes a lot of physiological disturbance, many a time fluid shift, blood and blood product transfusion, which causes a hemodilution and a dilution of the coagulation factor, and to some extent inflammation. So all these factors causes a risk of coagulopathy in these patients, particularly patients where the risk of blood loss is more, like patients undergoing aortic vascular surgery or other thoracic vascular surgery or any other cancer surgery where massive blood loss is a possibility. Second scenario is a trauma, be it blunt trauma or a penetrating trauma. Whenever the trauma is associated with a significant blood loss, so there is a terminology we are aware of the fact that trauma-induced coagulopathy. So trauma-induced coagulopathy is a multifactorial, which is beyond the scope of this particular talk. So in short, trauma causes a coagulopathy early, and it is multifactorial, both because of the hemodilution, blood loss, and activation of the inflammatory cascade. So that causes a coagulopathy. Trauma-induced coagulopathy is considered to be a risk factor of poor outcome in this patient. Thirdly, the cardiopulmonary bypass. Cardiopulmonary bypass is a different physiological concept where during the cardiopulmonary bypass, there is the activation of the inflammatory mediators, there is a blood loss, there is a hypovolemia, which is managed by the crystalloid and colloids. All these factors contributes to the postoperative blood loss along with the platelet dysfunction, which is unique in this scenario. Fourthly, end-stage liver disease. So as you all know that end-stage liver disease, normally it is usually associated with a decrease in all coagulation factor, but patients who are in a compensated phase of end-stage liver disease, they don't usually bleed. Rather, they have a tendency to develop thromboembolic complications. But in case of a alteration of the physiological status like infection, upper GI bleed, they causes a coagulopathy and possibility of significant clinical bleeding, which requires a specific management. Fifth, the obstetric hemorrhage. Obstetric hemorrhage, it's an important scenario in our country and in the Western world also. So management of the obstetric hemorrhage, along with the surgical factors, there are specific medical considerations like alteration in the physiology in the pregnant woman and risk of life to the both mother and the fetus. That's why the management of the obstetric hemorrhage is particularly important. Lastly, patients on the anticoagulants. The patients who are on anticoagulants nowadays, with the aging population of our country, we see more and more patients who are taking anticoagulants for various reasons like atrial fibrillations or prosthetic heart valve. They come to the ICU for different reasons, like patients may be having with upper GI bleeding, patients they may be undergoing some surgery at times, major surgery, or they may come with a intracranial hemorrhage. So these 5 or 6 scenarios, they require a specific management from the hemostatic point of view. Now, before going to the specific pharmacology, let's discuss about the basic pathophysiology of hemostasis, tissue injury, and control of and the blood loss. So whenever there is a vessel injury, be it because of the surgical trauma, be it because of the stress, or because of any other reasons, three things primarily happens. So the blood vessel constricts because of the activation of the sympathetic nervous system, and there is a platelet activation at the site of tissue injury, and simultaneously there is activation of the coagulation cascade. So platelet activation and activation of the coagulation cascade, they are not independent of each other. They are dependent, and activation of coagulation cascade actually causes platelet activation, and platelet activation ultimately causes the coagulation and formation of the fibrin plug. So which ultimately prevents the further blood loss at the site of the tissue injury. Along with this, that the human body contains a robust system of anti, you can say that antifibrinolysis, sorry, fibrinolytic system. So the fibrinolytic system prevents the formation of blood clot beyond the site of tissue injury. So in the absence of a fibrinolysis system, there would have been a clot formation in the intravascular area also, which is detrimental for the human physiology. So this is the basic pathophysiological concept, that is the classic textbook teaching. All of are well versed with this concept. Like coagulation pathway is divided basically into two parts. One is the intrinsic pathway, and there is an extrinsic pathway. The intrinsic pathway, they are activated by the high molecular weight kininogen, preclaniclin, and they are with the surface contact. And the extrinsic pathway is that it is activated by the tissue injury at the site of injury by the tissue factor. Tissue factors are expressed mainly in the vascular smooth muscle cells, and also in the some amount of in the human monocytes. So tissue factor ultimately activates the factor 7. So from the factor 7, the factor 10 is activated. So ultimately the factor 10 activates the thrombin. So thrombin is the key concept behind the generation of fibrin plug and the formation of the clot. Similarly, the intrinsic pathway, which is mediated by the factor 12, 9, 11, and factor 8. So they also finally, in the final common pathway, they also activate the thrombin, which causes formation of the fibrin plug and ultimately the stoppage of the bleeding. Now, this old concept is being challenged day by day. The recent physiological concept is has changed from a extrinsic and intrinsic pathway to a cell-based concept, cell-based pathway. So all the functioning of the coagulation system, they happens at the cell wall, at the cell membrane. At the level of the cell membrane, mainly at the platelet and the cells which expresses a tissue factor. So the current concept says that the coagulation pathway has three overlapping stages of varied duration: the initiation of coagulation, amplification of the coagulation, and propagation. So this slide is important to understand the various steps of the coagulation and which particular therapy to be used for a particular kind of pathophysiology. So basically, in a nutshell, the coagulation cascade is activated by the tissue factor and the factor 7A complex on the cells which expresses the tissue factor at the site of injury. So these complex activates the factor 10 and factor 9. Ultimately, it generates a small amount of thrombin from prothrombin. These thrombin, actually, the small amount of thrombin in the initial phase of coagulation activates the platelet through a factor 5 pathway, and this causes a burst of thrombin generation from the activation of platelet by factor 9 and 8 complex and factor 10 and 5 complex. So these are two important complexes, 10 and 5 and 9 and 8, which ultimately generates a burst of thrombin from a prothrombin at the level of the platelet. So platelet activation is a key factor for generation of thrombin. Initially, the thrombin monomers are generated. So whenever the fibrin monomers are generated, whenever the fibrin monomers are generated, they trap the red blood cells and other platelets to generate the fibrin polymer, and ultimately clot is formed. So our antifibrinolytic system, they have a checks and balance to limit the fibrin formation only at the site of the tissue injury, not at the other distant site. So whenever the coagulation pathway is activated, remember there is always activation of a sympathoadrenal system and also the inflammatory system. So our inflammation and the coagulation pathway, they always crosstalk to each other. We have several anticoagulation pathways, like the antithrombin is the most important thing. Previously, it was called the antithrombin 3. Now it is named as only antithrombin, not the 83. Protein C and protein A's, tissue factor plasminogen inhibitor, and the protein Z dependent protease inhibitor. So these five are the most important anticoagulant pathways. So to limit the thrombosis only at the site of tissue injury, and so that distant organs are preserved. Now, basic workup for bleeding. Many a times when you receive a patient who is bleeding, we know the background history. Like patient might have come to the ICU after a cardiopulmonary bypass or cardiac surgery, might have come to the ICU after a laparotomy for a major trauma, or patient might have undergone a upper GI endoscopy for a GI bleed, a patient who is having a end-stage liver disease. So our workup for bleeding should focus on the basis of the primary pathophysiology, why the patient has come to the ICU. Along with this, when we don't know the cause of bleeding, so because of various reasons, so these 5 or 6 investigations are bare minimum to start with: the complete blood count and the platelet count. So along with that, it is desirable to do a peripheral blood smear also to see any abnormal platelets are there or not. Second is the P time and the INR. As you all know, the P time and INR, and they are, I'll come detail into how they are interpreted. And the activated partial thromboplastin time, thrombin time. Thrombin time basically is a marker of fibrinogen activity and serum level of fibrinogen, platelet function assess, and the point of care test. Regarding the platelet function assess, they should be only ordered in a specific clinical scenario, not routinely. Point of care test, yes, they are very important. Point of care test rapidly gives us a result, and it indicates the requirement of a specific therapy whenever thromboelastogram or rotem, whatever things are available, should be used in an intensive care setting to early diagnosis of a particular uh, coagulation factor deficiency. So as I have told that this is the basics of our coagulation cascade. The P time or the INR, they normally denotes the deficiency. The elevated P time denotes the deficiency in the extrinsic pathway. That is the factor 7 is the primary mediator. And the APTT normally denotes the abnormality in the intrinsic pathway, like factor 9, 11, 8, and ultimately the factor 5, which comes into the final common pathway. So in the abnormality of a particular test gives an idea that which pathway has been affected by the primary disease. Next, coming to the point of care test. So thromboelastography nowadays, it is available in most of the ICUs. It is a low cost investigation to see the formation of clot, the strength of the clot, and the how the clot are being lysed. So whenever the thromboelastography is plotted, these 4 or 5 parameters are being plotted both graphically and numerically. So the first is the R time or the reaction time. So it is the time which is dependent on the coagulation factor. Second is the time of clot stability to reach a stability. There's the K time. So it is mainly dependent upon the fibrinogen concentration of the plasma. Next, the alpha angle. Alpha angle also fibrinogen dependent. It denotes the speed of formation of clot. The maximum amplitude, or it denotes the strength of the clot. It is primarily affected by the platelet function and number, also to some extent dependent upon the fibrinogen concentration. Lastly, the lysis time or the fibrinolytic pathway, as I have told you that our human body, whenever there is activation of the coagulation pathway, there is activation of the fibrinolysis also. So activation of the overactivation of the fibrinolysis also destabilizes the clot and then increases the chance of bleeding. So the LOI 30 or the lysis 30, it denotes the activity of the fibrinolytic phase. So this is a typical picture of a normal thromboelastography that can be seen under physiological conditions. So with this background knowledge, Let's look into the few abnormal thromboelastographies. So if it is an abnormal, a normal thromboelastography, you can look into is the effect of anticoagulants. So where the R time is significantly primarily increased. So now when patients, suppose this is the typical thromboelastography, when a patient is receiving platelet blockers or antiplatelet agents like aspirin, clopidogrel or ticagrelor, you can see the maximum amplitude is significantly reduced. Fibrinolysis is seen many a times in particularly in postoperative patients, in trauma, in obstetric hemorrhage. So here, so the clot destabilizes early in the course of time. Hypercoagulation, yes, that can be also seen in many a scenario in intensive care units, but not normally with patients with bleeding. DIC, where the initial phase is associated with the hypercoagulation, later on, all the coagulation factors are affected, and ultimately the R time, K time, and the maximum amplitude all are reduced in the second stage or the late stage of the DIC. Now, how to interpret the thromboelastogram? So thromboelastogram, it is not only diagnostic, it gives you an idea, so which therapy to be used. So this table is important for day-to-day clinical practice. Whenever you see that R time is prolonged beyond 10 minutes, normally some says 8 minutes. So there is a probably a deficiency of the coagulation factor. So fresh frozen plasma is the treatment. I'll come to the details of each each component of coagulation management in detail later on. So whenever the K time is prolonged, so it is normally 1 to up to 3 minutes is the normal. So fibrinogen is deficient, and alpha angle prolongation of alpha angle also causes deficiency of, it's caused by the deficiency of fibrinogen. Maximum amplitude, it is the strength of the clot. It is primarily affected by the platelet. So whenever you think there is a deficiency in the platelet, so platelet transfusion or use of desmopressin is indicated. So lysis normal value is up to 10% or 8%. Excess fibrinolysis is managed by the lysine analogs, the tranexamic acid or the epsilon amino caproic acid. So tranexamic acid and nowadays in all practical purpose is commonly used. Now, after that, when you have diagnosed a specific clinical scenario in a background of these 5 or 6 conditions where specific hemostatic management is required. So you have an armamentarium of 6 or 7 group of agents which are required in this specific clinical scenario. Now, in this portion of my talk, I will discuss each agent individually, their indications, their concerns, and what is the evidence in support or against the use of a particular drug. The most commonly used hemostatic agents in clinical practice, the antifibrinolytic agents. They are the tranexamic acid and the epsilon amino caproic acid. Now, what they do? They are basically lysine analog. So they binds to the lysine binding site of tissue plasminogen activator, plasminogen, and plasmin complex. And basically, what they do, they prevents the release of plasmin. So plasmin causes degradation of the fibrin to fibrin degradation product. So ultimately, plasmin causes a clot lysis and it increases the chance of bleeding. It is an intrinsic checkpoint of our coagulation system. But whenever the tranexamic acid is used, the plasmin release is prevented. So ultimately, the clot strength is increased, the clot lysis is prevented. So it's in a nutshell, the work of a lysine analog like a tranexamic acid or ESA is to stabilize the clot. And tranexamic acid from dose to dose is more potent than ESA for all practical purpose. Nowadays, in majority of the ICUs and the perioperative setting, tranexamic acid is the most commonly used lysine analog. Now, what are the clinical use of tranexamic acid or the lysine analogs? The US FDA approved use is heavy menstrual bleeding, so which is not relevant to in our practice. For our practice, the evidences are there in support of these 4 or 5 indications. First is a postpartum hemorrhage. Postpartum hemorrhage means whenever the blood loss is more than 500 ml after a vaginal birth or 1 liter after cesarean section. So 1 gram of tranexamic acid bolus and a second dose can be given. So there is a strong indication. There is a large randomized control trial I'll discuss later on. So which shows there is a specific mortality benefit, blood loss related mortality benefit in this clinical scenario. Secondly, the trauma. So whenever there is a risk of bleeding or the patients are already bleeding, the early use of tranexamic acid within 8 hours, 1 gram followed by a 1 gram another dose if it is required. So this is also supported by a large randomized control trial. So I'll come to details later on. In cardiothoracic surgery also, the tranexamic acids are mostly routinely used. So as clot lysis is, incidence of clot lysis, excessive clot lysis is very high in this clinical scenario. So though there is no large randomized control trial, but several randomized control trial has been conducted in this scenario, and it is as usually associated with a better outcome with the use of tranexamic acid. Yes, orthopedic surgery, another indications, particularly patients who are undergoing spine surgeries where the risk of blood loss is quite high, and the joint replacement surgeries. So in this kind of scenario, so tranexamic acid is being used. So the dose, whatever mentioned in this slide, is the standard dose. So people have evaluated the standard dose versus a larger dose, a higher dose, like a bolus of 100 milligram per kg instead of 10 milligram per kg. Probably it has been found that higher dose is more efficacious, but the benefit is marginal. So as of now, for all practical purpose, it is prudent to stick to the standard dose, which is being used in the large randomized control trials. So there are several other uses also, so which are less important in intensive care bleeding. They are more important in the routine hematology practice. Along with this, yes, tranexamic acid is beneficial in patients with hemoptysis. So both tranexamic acid and epsilon aminocaproic acid has been used. We have a moderate quality of evidence. There are randomized control trials are there, which have found that significant improvement with the use of lysine analogs. So as I was discussing, the what are the evidences in support of using tranexamic acid? Uh, the latest trial, or it's a very big trial is available, the Omen trial. I think all young intensivists must know in detail about this trial. So this trial has found, so when tranexamic acid is used in patients with postpartum hemorrhage, the definition what I mentioned earlier, it is associated with a significantly decrease in the death due to bleeding. Though the all-cause mortality didn't significantly differ between the tranexamic acid and group, but the death from the bleeding was significantly reduced with the use of tranexamic acid. So whenever we are encountering this kind of clinical scenario, tranexamic acid should be used in all patients. Next, the crash two trial. Mm, Probably many of us are aware of the fact. This is also a large randomized control trial that just conducted in patients, trauma patients who were bleeding or at risk of bleeding. The tranexamic acid loading was used within 8 hours of injury. It was associated with the risk of death due to bleeding was significantly reduced, and simultaneously the all-cause mortality. Interestingly, the all-cause mortality was also significantly reduced with the tranexamic acid in patients with a trauma with bleeding or at the risk of bleeding. Lastly, the CRASH 3 trial, it is a recent trial published in 2019. This trial was conducted in patients with a traumatic brain injury. So initially, the author of this trial, they used tranexamic acid within 8 hours of injury. Later, they realized that 8 hours was too late in this particular clinical scenario. Then they changed the protocol to they used tranexamic acid very early in the course of the disease within 3 hours of injury. So in patients with mild to moderate traumatic brain injury, so the use of tranexamic acid within 3 hours was significantly associated with the better outcome, the risk ratio of 0.78 with a confidence interval of 0.64 to 0.95. But there was no benefit was seen in patients with a severe head injury. So in this clinical condition also, like mild to moderate mild to moderate head injury, where the patient comes early to the ICU, there is a scope of uh, use of tranexamic acid, particularly if the patient comes within 3 hours to the ICU or in the operating room. So in a nutshell, the clinical use is the postoperative bleeding, joint replacement, spine surgery, liver resection surgery, obstetric hemorrhage, and obviously the trauma. So the standard dose I have mentioned, 1 gram bolus followed by when the infusion is required, 1 milligram per kg per hour, or depending upon the clinical scenario. So the adverse effects, the most important adverse effect of this lysine analog is a seizure. The risk of seizure is significantly increased in patients with renal dysfunction. Whether the risk of venous thromboembolism and pulmonary embolism is increased with the use of antifibrinolytic agent, it is debatable. Most of the studies has found the incidence of VT and P are not much increased with the standard dose of tranexamic acid in the clinical scenarios where it has been found to be beneficial. So this is not a real life concern, but seizure, yes, it may be important concern, particularly where a higher dose of tranexamic acid is used and in patients with a renal dysfunction, because tranexamic acid is primarily excreted in the kidney by the kidney in the urine. Next, coming to the prothrombin complex concentrate. PCC is a relatively newer concept. So basically, as the name suggests, PCC contains the 4 important coagulation factor, which is called a 4-factor PCC or a 3-factor PCC. So what is the difference between 4-factor PCC and the 3-factor PCC? The 4-factor PCC, it contains factor 2, 7, 9, and 10, and the 3-factor PCC doesn't contain factor 7. So this is the practical difference. So in all clinical scenario, it has been found that 4-factor PCC is usually more efficacious, but in case of a non-availability, 3-factor PCC is also an alternative, and factor 7 can be supplemented. The recombinant factor 7 can also be supplemented along with the 3-factor PCC. It contains the anticoagulants also, like protein C, protein S, and to some extent heparin also. And importantly, it doesn't contain factor 5. What is its advantage? The most important advantage is the concentration of these 4 clotting factor is 25 times of the plasma. So you require a less amount of volume to supplement in this clinical scenario. So studies have found that when 4-factor PCC is used along with a 1:1:1 transfusion protocol, that is the standard transfusion protocol in major trauma and massive blood loss, it is associated with a reduction in some reduction in the transfusion requirement, but not improvement. There is no improvement in the other outcomes like organ dysfunction, like mortality, duration of hospital stay. The patient-centered outcome were not improved, but yes, transfusion requirement was reduced with the use of 4-factor PCC along with the 1:1:1 transfusion protocol. And it has been used to reversal of the anti-factor 10A related bleeding also, though it's an off-label indication. And 4-factor PCC is commonly used when perioperative bleeding and intraoperative bleeding in patients who are undergoing liver transplant. So liver transplant is associated with a lot of coagulation abnormality. So it is being used so widely in patients who are undergoing liver transplant. So PCC has several advantages over FFP. What are those? Basically, first of all, the APCC can be administered very quickly. As you all know, that fresh frozen plasma needs to be thawed at 30 to 37 degrees centigrade before infusion in the patient. So it takes time, though nowadays there are devices available which for by the devices, FDA approved devices are available by which the FFP can be thawed within minutes. But I think in most of the ICUs it is not available, or most of the blood banks they don't have access to the device. So PCC can be administered over a few minutes as opposed to the FFP. Secondly, as the volume is much less than FFP, so PCC is safer, particularly in patients with heart failure and patients with renal dysfunction and oliguric patients. Like many a times, we encounter patients who have undergone valve replacement and has come for bleeding from some other source who requires urgent reversal of the warfarin. So in this clinical scenario, if the PCC is available, it will be probably safer over FFP just because of the volume advantage. So thawing also, as I mentioned, at times it delays in administration and anticoagulation reversal, which is not with the use of PCC. Next, PCC is leukocyte free and is less likely to cause infusion reactions like urticaria, fever, angioedema, etc. The incidence is much less. As it is leukocyte free, the risk of transfusion associated acute lung injury and ARDS, they are significantly less with the PCC as compared to FFP. And it also causes much less risk of viral transmission, though the risk of viral transmission with the FFP is also not that much high in the current advancement in the transfusion medicine practice, but still the risk of viral transmission is even lesser with the PCC as compared to the FFP. So what are the approved indications for PCC? The only USFDA approved indication for PCC is the vitamin K antagonist induced coagulopathy. That is warfarin induced coagulopathy. So if there is a need for reversal of these coagulopathy, the PCC can be used. So the dose is dependent upon the INR. So when the INR is 2 to 4, 25 units per kg. When INR is 4 to 6, it is 35. And if the INR is more than 6, the 50 units per kg is required. And the maximum dose has been calculated up for a body weight of 100 kg. Normally, the repeat dose and subsequent dosing is not recommended, but monitoring of the INR after administration of the PCC is required to see the effect. So this is the only USFDA approved indication for PCC. However, there are several off-labels used. Actually, the off-label use are number of off-label use are much higher than the actual approved indications. So PCC is being used for reversal of the near anticoagulant induced anticoagulation. I'll come details of these later on. And they are being used to reduce the perioperative bleeding, both for prophylaxis and treatment with limited evidence. It is being used trauma setting along with a massive transfusion protocol, and it is also being used for treatment and prophylaxis of bleeding in congenital deficiency of any of the vitamin K dependent coagulation factors. Now, what is the evidence of using PCC? Does it really help? So, if we go by the literature, the older literature, the retrospective studies, mostly they show there is a improvement in the transfusion requirement. Less patient number of RBCs are transfusion required, and less number of patients requires transfusion. So, but advantage in the clinical endpoint like organ dysfunction, hospital stay, or mortality are not much. So the randomized control trials in this scenario is scarce. So with the extensive search, I have only come across these randomized control trial. It was published last year. So it was conducted in the post CPB patients. So it has been found that though the use of PCC were associated with the greater improvement of the P time and the earlier normalization of the INR, uh, all the other clinical outcome, they were not improved. So there is only improvement in the requirement of intraoperative RBC transfusion. That's it. Total intraoperative transfusion rate was also not significantly different. So whether you should use a PCC in this particular clinical scenario, CPB, it is debatable. Probably it offers very little advantage over the standard management of coagulation. Another systematic review also, it was also recently published systematic review. That systematic review says that insufficient data exists on the effect of FFP versus PCC administration before invasive procedure in patients with coagulopathy liver disease. In this clinical scenario also, probably there is a earlier and higher rate of correction of PT and INR, but bleeding outcomes were not significant. So it is important because many a times in patients who are having an advanced degree of liver failure, FFP administration causes a volume overload. So in this clinical scenario, so PCC is as good as FFP and with a less volume. So if the volume is a concern, PCC may be a better alternative in this particular clinical scenario. Next, coming to the fibrinogen. Fibrinogen is the probably the single most important coagulation factor in clinical bleeding scenario, because in case of a massive hemorrhage, this is the first factor to get reduced below the physiological range. The normal physiological range into 200 to 400, some says 450 milligram per deciliter in non-pregnant patient. In pregnant patient, particularly in the third semester, this level is increased a little bit. So normal guideline, usually the guideline says the target level is that you should target at least 1 gram per liter or 100 milligram per deciliter of fibrinogen level at the time of massive trauma or hemorrhage or post-surgical patients. European guidelines, they suggest that you should maintain at least 200 milligram per deciliter of serum fibrinogen level. So how it works, as I have already shown in the second and third slide, that the tissue factor, which ultimately activates the prothrombin to thrombin. So thrombin causes activated thrombin causes formation of fibrin monomer from the fibrinogen. So this is the first step of formation of a clot, the fibrin monomer. So they are later cross-linked and they trap the other cell like RBCs to form a definitive clot. So how the fibrinogen can be supplemented? Fibrinogen can be supplemented by the fresh frozen plasma or FFP also. But the problem with the FFP, when it is used solely for fibrinogen supplementation, that it contains a variable amount of fibrinogen. It may be 1 to 3 gram per liter, depends upon the fibrinogen concentration of the donor. So even a standard dose of FFP use, the increase in fibrinogen level is very small. It is 400 milligram or 0.4 gram. More than 30 ml per kg of plasma causes increase in fibrinogen level, which is the desired therapeutic level of 1 gram per liter. So at least you should use a 30 ml, more than 30 ml per kg of plasma. So in a 50 or 60 kg patient, it comes around 1.5 to 1.8 liter. So again, the concern remains the volume. So the large volume is required to achieve a therapeutic level of fibrinogen in patients who are actively bleeding. So it may be feasible in patients who are undergoing major surgery where high volume infusion is required, or a trauma resuscitation when volume resuscitation is not an immediate concern. But other clinical scenario, it is difficult to achieve, like 1.5, 1.8 liter of extra fluid, which might cause a fluid overload. And secondly, how much it is efficacious the plasma in this particular scenario, it is difficult to say. So we have other alternatives. We have fibrinogen concentrate, and the most commonly used is in our setting is a cryoprecipitate. So in a 70 kg adult, the 5-unit cryoprecipitate increases fibrinogen level by 25 to 35. So normally 3 to 4 gram of fibrinogen is recommended, or which accounts to around 15 to 20 unit of resuscitation in a patient with actively bleeding to support the fibrinogen level around 100 to 200 milligram per deciliter. Though the target fibrinogen level is debatable, so some says 100, some says even 80 is also good enough. But if you go by the European guideline, you should target somewhere between 150 to 200 in this particular clinical scenario. Now, what are the evidence in support of using fibrinogen supplement? So in trauma setting, it has been found that low fibrinogen level is associated with higher chance of bleeding, higher mortality, and higher organ dysfunction. So in major trauma, whenever the fibrinogen is supplemented, has been universally found to be associated with a less transfusion requirement and probably some degree of less organ dysfunction. But interestingly, no effect on mortality has been found even in a trauma setting where low fibrinogen level is very common. So prophylactic fibrinogen use has been not been found to be associated of benefit in any clinical scenario. And however, one thing it is important to emphasize that when fibrinogen is used for in an indicated cases, it is not associated with a increased incidence of venous and arterial thrombosis. So the risk of complications is not increased even with the use of a fibrinogen level. Next, coming to the guideline, dosing guideline. So dosing guideline can be done on the basis of the serum fibrinogen level, can be done empirically, and can also be done by the FIB10 level also. FIB10 data like the A10 in the FIB10 and the CA10 in the trauma-related FIB10. So basically, the advantage of the FIB10 is that from the FIB10 semi-quantitatively, one can assume the fibrinogen level and can decide on the dose of fibrinogen according to the fibrin value. If you don't have access to the FibTem, so it can be done empirically, particularly in patients where the fibrinogen level is less than 200, in cardiac surgical patients at 25 milligram per kg, or when it is less than 150 milligram or 50 milligram per kg of fibrinogen is good enough. In liver transplant patient also and trauma, FibTem and is being used when it is available. These dosing guidelines can be utilized. But otherwise, an empirical dosing like a 3 to 4 gram of fibrinogen in patients with actively bleeding because of any cause, and it is expected to be associated with a low fibrinogen level, can be used empirically. Next, coming to the recombinant factor 7A. So recombinant factor 7A, as you remember that ultimate how it works, the recombinant factor 7A activates factor 10 to factor 10A, which ultimately activates the platelet for generation of the thrombin. So it works by activating the platelet. So there was a lot of enthusiasm in the initial days of recombinant factor 7A. It's costly, and it has a short elimination half-life of around 2.6 to 2.8 hour, and half-life is even lesser in children. The dose of recombinant factor 7A, it's wide. It depends upon the indication. Now let's see what are the approved indication. The US FDA approved indications of recombinant factor 7A in patients with hemophilia A or B with the inhibitors. So if these patients, if you encounter hemophilia A and B patients in your ICU with bleeding in the joints or some other spaces, so the standard recommended dose is 90 to 120 microgram per kg every 2 hours. It has been used in Glanzmann's thrombasthenia also, and in factor 7 deficiency. Isolated factor deficiency is actually very rare, but however, in case of factor 7 deficiency, it can also be used. However, as with the other hemostatic agents, the use of recombinant factor 7A, the off-label uses are much higher than the FDA approved uses. The commonest off-label use is a traumatic bleeding. Though most of the guidelines nowadays, the recent guidelines, they don't recommend the routine use of recombinant factor 7A. Most of the guidelines nowadays recommend so use of factor 7A only as a rescue therapy. So when you have ensured that platelet count is adequate, fibrinogen level is adequate, there is no acidosis and no hypothermia, like the pH is more than 7.2 and core body temperature is 34 degrees centigrade. Still, if there is a bleeding in the absence of a coagulopathy, recombinant factor 7A can be tried. And but again, the benefit in this clinical scenario is doubtful. So routine use for perioperative and traumatic bleed should not be encouraged uh, of factor 7A. Another important concern that a meta-analysis in 2011 published in NEJM, it showed that when the recombinant factor 7A was used, there is a significant increase in the incidence of arterial thrombosis. Though the incidence of venous thrombosis was numerically higher, but still it didn't reach the statistical significance. But in case of arterial thrombosis, there is a significantly increased incidence of arterial thrombosis with the use of a recombinant factor 7A. Particularly, this risk is higher in patients who are older or the patients who are already at the risk of arterial thrombosis, like patients with dyslipidemia, patients with arteriosclerosis. So use of factor 7A in this particular clinical scenario should be discouraged or should only be used when it is absolutely necessary. Now, let's come to the last factor, isolated factor, which is available commercially, which can be used in clinically, like the factor 13. So it can also be recombinant and plasma derived. So the only approved indication of this factor 13 is the congenital factor 13 deficiency, which is very common. Sorry, it is very uncommon. However, acquired factor 13 deficiency in patients with massive hemorrhage is actually very common. But still, it has been found that supplementation of factor 13 in this clinical scenario is not associated with the improved outcome, nor it decreases the transfusion requirement. So it is not recommended in routine hemostatic management in any clinical condition except the congenital factor 13 deficiency. Next is a desmopressin. Desmopressin per se is not a true hemostatic agent, but how it works, it actually releases the von Willebrand factor multimers from the endothelial storage by V2 receptor agonistic activity. So as you all know that von Willebrand factors enhance the platelet adhesion to the endothelium and ultimately platelet activation. So a dose of 0.3 microgram per kg of the slow IV infusion, it should always be used as slow IV infusion because it is associated with both, it can be associated with both hypertension, flushing, and other hemodynamic changes. So the indications are approved indication of mild hemophilia A and von Willebrand disease, but it has been used in other scenario like in uremic bleeding in patients with cardiac surgery with some limited efficacy. Lastly, I'm coming to the fresh frozen plasma. Fresh frozen plasma, as of now, we have discussed all the individual component of the hemostatic enzyme. So fresh frozen plasma, it contains all the coagulation factors, including the anticoagulant factor. So typically, one volume contains 250 ml of fresh frozen plasma. It contains around 400 to 900 milligram of fibrinogen. The recommended dose is 10 to 20 ml per kg. So 10 to 20 ml per kg is physiological studies have found that it is associated with an increase in clotting factor, average clotting factor by 20%. But studies have also found that even an increase on clotting factor by 10 to 15% in most of the time is sufficient to arrest bleeding. So whether the 10 to 20 ml per kg dose should be used in all patients or we can try with a lower dose, it is doubtful. So fresh frozen plasma is stored at minus 30 degrees centigrade and it has to be thawed before infusion at 30 to 37 degree centigrade and it takes time and it should be administered immediately after thawing. And however, it can be stored in 1 to 6 degrees centigrade for 24 hours. Remember that factor 5 and factor 7, factor 8 activity declines after thawing with time. So ideally, it should be administered as soon as possible, but it can be delayed in case when it is required up to 24 hours. And fresh frozen plasma, though it contains all the coagulation factor, one should remember that factor 7 has a small half-life, short half-life. So fresh frozen plasma might need a repeated administration, particularly when the factor 7 is deficient in patient. So what are the indications? Fresh frozen plasma is currently indicated in a massive transfusion protocol. So massive transfusion protocol, the protocol were originally derived from the military trauma, from different war protocol or studies conducted during the war times. It has been found that if one transfuse platelet, RBC and FFP in a equal ratio, or a platelet and FFP of half of the RBC, it is associated with a better outcome. So as of now, there is lack of data to suggest whether 1:1:1 or 1:1:2 protocol is better. So it depends upon the local hospital protocol. Normally in our trauma setting, we use 1:1:1, or in case of massive hemorrhage, we try to maintain a ratio of 1:1:1. And subsequently, we guide our therapy by thromboelastography or the ROTEM, whichever is available. So this is the primary indication of FFP. Along with that, FFP can be used for reversal of the vitamin K antagonist induced bleeding. So it can be used also in if there's some patients with end-stage liver disease also bleeding or some procedure needs to be done in this group of patients. It can be used in post-CPP bleeding also if it is associated with a coagulopathy. And lastly, the last indication is not truly hemostatic indication, but yes, in patients with thrombotic thrombocytopenic purpura for plasma exchange or other causes of plasma, other indications of plasma exchange also, FFP is used. So there are a few concerns with the use of fresh frozen plasma. I have already discussed the volume overload is the most important concern, particularly in patients with end-stage liver disease, patients with heart failure, patients with acute kidney injury, or even patients with chronic kidney disease. So volume overload is the most important concern. Transfusion associated acute leg injury, yes, it is also possible with the use of FFP. Infectious complications, yes, theoretically possible, but nowadays practically it is much less than which was reported long ago. Allergic reactions is also a possibility because it contains the leukocytes also at times. Now, lastly, I'm coming to a special interesting topic, the reversal of the BK antagonist and the newer oral anticoagulant drugs. So if we go by the guidelines, so ideally the vitamin K related antagonist like warfarin related bleeding should be antagonized by a 4-factor PCC when it is available. This is the ideal way of reversal of a vitamin K antagonist related to the bleeding. Along with that, vitamin K of 10 milligram IV should also be used. So when a vitamin 4-factor PCC is not available, the 3-factor PCC along with the activated factor 7 or an FFP is a reasonable alternative along with the vitamin K. When neither of the PCC and the recombinant factor 7 is available, FFP of 2 units it is recommended along with the checking of the INR, and if required, another 2-unit transfusion is indicated. So here again, the volume overload is an important concern, particularly in this group of patients. Often they have underwent a valve replacement and compromised cardiac function. That should be kept in mind. And along with that, whether you are using FFP or a PCC, vitamin K should be used in this patient. Next, patients who are on newer oral anticoagulants, like it may be dabigatran or rivaroxaban, apixaban, and edoxaban. These four are most commonly used drugs. If you are encountering in these patients in your intensive care unit, and when they are scheduled for some specific procedure or a surgery, you need to assess the bleeding risk of the procedure related to the particularly procedure, and see the kidney function of the patients. So the guidelines has been formulated for stoppage and restarting of this drug. Generally, when the risk of bleeding is high, so the last dose is given 3 days before the procedure, when the renal function is normal. And it depends upon the dose also, particularly in case of dabigatran, when the compromised renal function, it should be given 5 days before the procedure. In case when the procedures are minor, like in that case, it should be given 2 days before the procedure. And depending upon the postoperative bleeding risk, it has to be restarted 40 to 72 hours after the surgery or a procedure in case of high bleeding risk. And in case of low bleeding risk, it can be restarted after 24 hours. Now, what happens if these patients come to your ICU with a bleeding like an intracerebral hemorrhage or GI bleeding, where a immediate reversal is required? So immediate reversal, there are specific agents, USFDA approved specific agents are available. So if you have access to these drugs, like for dabigatran, idarosizumab is available. So if it is available in the ICU or in the hospital, it should be used. Like factor 10A inhibitors, apixaban and edoxaban and rivaroxaban. Etixanet alpha is the drug of choice. In case when etixanet alpha is not available, 4-factor PCC again is the important off-label use of 4-factor ECG, and weight based regimen of 25 to 50 units per kg has to be used. Thank you. Any questions, sir?
Thank you, Dr. Maitra, sir. Just switch off your share screen.
Okay, sir, just a minute.
If there are any questions from the audience, please put your questions, any comments. So just like to add to that couple of things while we wait for any questions. So as far as this bleeding from NOACS is concerned, or the newer anticoagulants, you can also administer charcoal, no, if they are bleeding. There's
Yes,
bleeding,
yes,
charcoal
yes, sir.
administration, and
Yes, sir.
dialysis also helps, though these
Yes,
are not hemostatic agents, just to manage the bleeding. And
yes,
of
sir.
course, tranexamic acid can also be given, TXA. So
Yes, sir. Right, sir.
these are the other things which can help in bleeding, because these are becoming very
Yes,
common. And as they become common, bleeding is going to be seen more and more with these agents.
right, sir. Right,
So
right,
management
sir.
of NOACS includes antidotes and PCC, and also tranexamic acid, charcoal,
Tranexamic is,
administration,
yes, off-label use of
dialysis.
tranexamic acid has also been used. There are a lot of case reports, case series, and studies are available, which is found is to be beneficial in the particular clinical scenario. Yes, and as you have mentioned, the charcoal, yes, that is also an option when a patient has already just taken the oral drug
So
to
just
prevent
one
its
thing I
further
would like to
absorption.
touch upon is platelet transfusion. Now, platelet transfusion, these are frequent questions from a young intensivist. So, normally 1 SDP is equal to 6 RDP, and if the patient's platelets are not being consumed actively, they should increase the platelet count by 30,000.
Yes,
But if
yes,
there is active
yes.
consumption, then it
Then the
cannot
increase
rise.
is unpredictable.
Yeah.
Increase in unpredictable. Many a times we see if there's a active consumption, there is actually no increase in the platelet count, or a minimal increase in the platelet count happens. So that's an important concern.
And
Uh,
what are the targets also for platelet counts? So if there is neurosurgery or major surgery or major bleed, you'd like to keep it at 1 lakh. If there is a
1 lakh. Minus in
less,
that case, 50,000 is good enough.
yeah. Okay, so 50,000 for biopsies and lesser surgeries, and
Yes,
for
yes,
invasive
sir.
procedures like central line around 20 to 30,000, and in DIC, so in DIC, and in other conditions, platelet counts alone cannot be taken by themselves. You have to look
Yes, sir.
at
Right, sir.
ECG, PT and the criticality of the situation also.
Yes, sir.
So in dengue, dengue is gone now, but dengue, if the patient is stable, 10,000 is enough. Don't transfuse.
10,000 enough. Yes, we also target in our ICU in dengue, we also target at 10,000. Exactly. In the
And
absence of other coagulopathy, 10,000 is absolutely acceptable.
in DIC, if there is no other coagulopathy and the patient is not critically ill, 20,000 is okay. You don't do
20,000 is
transfuse.
enough. Yes.
So these are,
Yes,
some of
sir.
the questions that they like to know about the targets, etc. So I was just covering that. Then coming to FFP. So you transfuse FFP, but what is the endpoint of transfusing FFP? So the endpoint is either the hemorrhage stops or you get
And the INR is one less than 1.5.
yes,
So many a
APTT.
times APTT normally we don't target with the FFP if we go by the guideline. If ideally, as you have mentioned rightly, that as soon as the hemorrhage stops, so it is the most important clinical endpoint of FFP transfusion. And in case you have doubt, yes, you should monitor the P time. And ideally, in a theoretical scenario, it should be less than 1.5. But many a times it is very difficult to reach the target of 1.5. So here also the clinical judgment comes into play. So if there is a no active bleeding, the platelet count is normal, probably a higher P time is also maybe acceptable.
Yeah.
So
Okay, then about tranexamic acid, you nicely showed the slide about the indications. The other one thing about tranexamic acid is not to be used in DIC because
yes,
DIC is something where there is no fibrinolysis. It
no
is very rare
fibrinolysis
to have fibrinolysis in DIC. So unless you can
is very
document,
rare.
you can only document with TEG. And if you
Yes, sir.
document fibrinolysis, then you can give TXA. But
Then
only 5 to 10%
is
of
rare.
DIC have
Yes, it is very
fibrinolysis.
rare.
Yeah. So you should not, this is
Yes,
very common because DIC and sepsis are very common. So if you have
yes, sir.
DIC, do not give TXA. It can actually lead to some more
Yes,
complications because the
yes, sir.
underlying pathophysiology is of coagulation of clotting in DIC. First there is clotting,
Yes, sir.
like you said, and then there is bleeding. So if there's
Yes,
underlying
sir.
clotting going on and you give TXA, you'll precipitate the clotting even more.
Exactly, sir.
To give
Exactly.
TXA, you have to document hyperfibrinolysis by TEG.
Yes, sir.
And that is only in 5
Yes,
to
sir.
10% of DIC.
Yes, sir. Actually, the main indication of lysine analogs like tranexamic acid is mainly in the post-operative patient and the trauma setting. Post-operative that includes both cardiac surgery, trauma, and obstetric hemorrhage, major surgery like orthopedic tumor. So where patient bleed profusely during surgery, maybe 10-liter, 8-liter bleeding is very common. So what we see in that case, the tranexamic acid for the next 24 hours, many a times we use an infusion. There is hyperfibrinolysis, as you have mentioned, is common. This is the only clinical scenario where it is used very frequently.
Yeah, and you see
And
now with the tag, you can easily document hyperfibrinolysis.
yes,
So
yes, sir.
you can use
TAG
it
is
more
available in our all
scientifically.
of our in most of the ICUs nowadays in India. So hyperfibrinolysis can easily be documented, and it's a low cost point of care investigation. Uh, it can be done in the intensive care side lab only, so no need to send it to the lab for this and wait for the investigation. By the time we manage the patient, stabilizes, the TAG report comes.
The other interesting use, which you also showed, was the inhaled tranexamic acid in pulmonary hemorrhage. So
Yes,
this
sir.
even I have read, and this has we have used also. So you can use by
We have also
inhalation.
used,
Yeah.
as of, we have not done a study, but yes, we have seen some benefit, probable benefit.
So and you
Uh,
talked about giving cryo for supplement and FFP for supplementing fibrinogen. So are you having fibrinogen concentrate in your
no,
blood?
sir, we use cryo. We
Okay.
use cryo. We
Okay.
use
Okay.
cryo, sir. We arrange cryo, particularly in patients where we are expecting a huge blood loss, like obstetric hemorrhage, placenta, abnormal placenta. They also bleed profusely, 8-liter, 10-liter, liver transplant, and some major orthopedic tumor where the blood loss is more than 5-liter, 6-liter. Yes, we arrange cryo.
So what dose should you give? You can tell the audience.
Sir, we target a fibrinogen level of more than 200. So basically 15 to we arrange around 20 units of cryoprecipitate in this clinical scenario. So in an average adult patient, we use 15 to 20 unit of cryo in
Yeah.
case if there is a massive hemorrhage, but obviously no prophylactic cryo. It is only if the bleeding is massive.
Yeah, and one bag is very small. It contains 10 to 20 ml normally.
Yes, sir. Yes, sir. Yes,
Okay,
sir.
then coming to uremic bleed. So for uremic bleed, which is again very common, one of the modalities is desmopressin, which you mentioned.
Yes,
Then you
yes,
can
sir.
use cryo, and then you can use dialysis. So all these three
Yes,
factors can be, these three treatment modalities can be used for
yes, sir.
uremic bleed.
Yes.
Then coming to desmopressin. So he showed you the dose 0.3 microgram per kg over half an hour. and this can be used BD, but there is nasal spray also. You can
Nasal
use
spray is
nasal
also
spray.
available. Nasal spray, actually, nasal spray previously we used to use for the last couple of years. Nasal spray is not available in our hospital. I don't know whether it is because of the company or some other administrative reason. So nowadays, nasal spray is not available. Otherwise, it was very convenient to use the nasal spray. And probably nasal spray was hemodynamically was associated with much stable hemodynamics than the IV. So, but unfortunately, nasal spray is not available presently at our hospital.
Okay. Then coming to PCC, so the trials may not have shown too much of an advantage, but one has to
Yes, sir.
understand that the volume is much less and you can use it immediately. So these are
Yes,
the
sir.
advantages, and
These are advantages. Yes. So when it is,
understanding the advantages, one can use it, but it's costly also at the same time.
it's
PCC is
costly.
much more
It's
costly.
costly.
So
It's much
those
more
factors
costly.
are
Yes,
to be
sir.
understood. And finally, a word about factor 7. So
Uh,
factor
that
7,
is the most overhyped factor, I think.
see, we have used factor 7 if there's nothing else happening. Okay,
Yes,
patient is
exactly.
dying
As a
from
rescue
bleeding.
therapy.
Yeah,
As a rescue therapy.
patient is dying from bleeding. You have tried
Bleeding.
everything,
Yes.
then you don't lose anything, right?
As a rescue therapy, even the all the guidelines also, the international guidelines regarding hemostasis, they also recommends, as you have mentioned, that is when all agents has failed and you have achieved a reasonable coagulation parameter, no hypothermia, no acidosis, factor 7 as a rescue therapy as a last discharge should be tried.
Yeah, so the dose is like he showed you 90 microgram per kg standard
90 to
can be
120,
used
90 is the standard. So some
can be
says the
used.
lower dose is maybe
Yeah,
also good enough,
45
but
can also be used and then repeat after
45
three
people have
hours.
used, sir. Yes, sir.
Yeah, and there is an incidence of 5% MI. So as a
Yes,
therapy, it can be used, but it is extremely expensive. 90 microgram
extremely
that is 7
expensive.
kg
Yes, sir.
thousand.
Absolutely. That's the main limitation in our setting. And I think it is in most of the setting.
Yeah, and it becomes very difficult in corporate centers to give an injection like that and the patient dies. But
Yes,
people can afford
exactly,
it.
exactly.
Okay, I think there are
Uh,
no questions, Dr. Sauvik Mitra sir. Thank you so much. So nice.
Thank you, sir. Thank you for your invitation and thank you
Yeah,
for
we'll
your
see you
nice
again now. Thank
conclusion,
you
sir.
so much.
Yeah,
Thank you.
right, sir. Thank you. My
Bye.
pleasure. Thank you, sir.